So up next is a panel discussion on caregiving. And we had a panel last year and it went very well. So we thought, let's bring this model back this year. And as you've seen so many times now throughout a lot of the presentations at the Allied Health Professionals, caregiving keeps rising to the surface. So we're eager to have a longer conversation about this. So I'd like to invite Jessica Mabe, Melinda Kavanaugh, and Bugyeong Sun.
Hello.
To join me and Rachael.
Morning or afternoon or whatever time it is with everybody.
That's right. So hang on, I apologize. I have multiple scripts depending on where I am in my life.
I have to say the way you all set this up is really lovely, because that previous presentation was phenomenal, and it just perfectly flows into everything we're about to discuss. So well
Melinda,
done.
Thank you for commenting on that. Now, I will have to say at the APF, we consistently try and put all themes together. You will notice there were a few that were out of place, and that has to do with the timing. We certainly don't want somebody in England presenting at 2:00 in the morning just because they fit a theme. Well, I might want that, but nobody else wants that.
Well done. It absolutely shows. Well done.
All right, so how we're going to start this is I'm going to have everyone introduce yourselves and tell us a little bit about who you are and what you do. And we are going to start with you, Bugyeong.
Hello, everyone. I'm Bugyeong from Korean ALS Association. I'm also a nurse coordinator at ALS Clinic and Hanyang University Medical Center, and also a graduate student at Hanyang University and interested in ALS M&D care management. Thank you so much for having me here today. It's my honor.
And next up, Melinda, would you like to introduce yourself and tell us a little bit about what you do?
Absolutely. Thank you. I will echo what an absolute honor it is. These allied health professional meetings are always an absolute highlight of the year. So thank you for the invitation. Melinda Kavanaugh, I'm an associate professor in social work at the University of Wisconsin in Milwaukee. I'm also a licensed clinical social worker and have been for over 20 years. And I have worked for many, many years across neurological disorders, but my primary area of interest really is in ALS and motor neuron disease. And I focus pretty squarely on caregiving and the role that children and youth play as caregivers, and really just generally the role that children inhabit in families living with ALS and motor neuron disease. So whether that's caregiving, education about the disease, support, simply identifying that they are there, that's really what I am incredibly honored to be able to do with my life. So thank you. Thank you so much.
And actually, before I go to Jess, I assume that everyone knows who Rachael and I are because we've been with you for 2 days now, but my name is Sara Feldman. I'm the physical therapist and assistive technology professional at the MDA ALS Center of Hope in Philadelphia. And I'm also the clinical liaison for the ALS Hope Foundation. And Rachael and I will be moderating, and Jessica, Melinda, and Bugyeong will be the panelists for this. Rachael, do you want to introduce yourself quickly before we have Jess go?
Yep, very consultant nurse and care centre coordinator for the Oxford M&D Care and Research Centre in the UK. Thanks, Sarah.
And finally, last but not least, Jessica, would you like to introduce yourself?
Hi, thank you very much for having me here today. A little bit about myself. I'm a former caregiver to my mom alongside my dad. She was diagnosed in latter part of 2014 with ALS bulbar onset. She gave the brave fight until February 2018. A little bit sort of about the story around that, which I think will shape a lot of this discussion, is at the time when she was diagnosed, well, just before that, I was actually living and working in Dublin, very happy with, what my life was at the time. I remember that summer was the Ice Bucket Challenge was sort of hitting everywhere. And, like everyone who was exposed to it, but not part of the ALS MND community, we were touched and just learned a little bit about it. And you just sort of think, well, that won't happen to me. Little did I know that just a few months later, my mom would get the diagnosis of ALS MND. So this was in 2014. A few months after that, I took the decision to move back to Colombia after almost 20 years living abroad. Because I just knew, I think in a way, by being overseas, I got a little bit more exposed to what the illness meant, and moved back to Colombia. And alongside my dad, who was incredible across the whole journey, we cared for my mom. It was an interesting, challenging, but at the same time, priceless opportunity to spend time with both of them and with my mom. But I do think there were a lot of gaps with regards to what I needed as a caregiver, what my dad needed as a caregiver. And I had amazing support from the association here, who introduced me to the Alliance, where I became part of the PCAC Council, and shortly after that became Programs Coordinator for the Alliance. So I just wanted to give a little bit more of context around sort of my experience as a former caregiver now, because I think that would sort of help us with the discussion as we move forward.
Mhm.
Yes, thank you so much. And as you mentioned in your introduction, you're not only a caregiver yourself, but you're also an active member of a volunteer for ACELA. Could you just tell me, what does ACELA stand for?
So ACELA is the Colombian Association for ALS MND here in Colombia. It's an association purely run by volunteers. It was started by Orlando Ruiz, who is a person who has lived with ALS for, and I'm not going to give an accurate number because I probably will get it wrong, but it's close to 20 years. He is an amazing human being, and he just leads us in such a way that all of us that actually volunteer, we do it out of our time. We don't get remunerated in any way, but our focus is on sort of, by our own experiences, we help other families that are starting and are going through the ALS MND journey with regards to how to navigate it, because it is a question of navigating it in the best possible way.
No, thank you. That's really helpful. And not only that, you work for the International Alliance, and I wonder if you'd be able to share some of the findings on the recent survey you did on caregivers' rights.
Fantastic. Yes, I'll let the slides go around. It's a summarized version, but hopefully it'll give you a little bit of an insight of what we found on the survey. I will now share some of the findings from the responses of the ALS MND caregivers who took part in our fundamental rights survey held from 19th August until 27th September. Before I jump into the data, I'll quickly go through the fundamental rights for caregivers of people living with ALS MND. These rights are aspirational and might not be immediately attainable, but we hope they will be adopted worldwide as conditions, systems, and resources allow. Caregivers have the right to have access to information and education, to training and resources, to timely appointments and treatments, to remuneration. They also have the right to support in all areas and to provide input on the healthcare and support systems. From 1,086 responses, 474 came from caregivers. This image reflects the fundamental rights. The color codes reflect the various categories of that right. What jumped at us was the very low agreement numbers. Overall agreement was under 61% with a median of 30. If you think back to Kathy's presentation where she spoke about the PALS results, their median was of 45. Regardless of where you are in the world, caregivers feel very unsupported. Our orange bars represent the right to have access to information and education and timely appointment and treatments. This had the highest agreement. Our next bar refers to remuneration with 27% agreement. The purple bars represent support in all areas that include counseling, emotional, respite, and time for themselves, palliative, and bereavement advice. Notice how low they are, an average level of agreement of 26%. And the blue bars represent the right to provide input with a 33 and 32% agreement. Today, I want us to focus on support for cows. As you can see in this image, all very low agreement figures. 37% agreed to receive to some sort of counseling. Palliative care and bereavement advice had a 28% agreement. Emotional support programs at 27% agreement. Time for themselves with 23%. Social or respite support with 22%, and the ability to plan for the future with 20%. Overall, we can see that cows are feeling very unsupported. We really need to consider that the caregiver's well-being has a direct effect on the cow's quality of life, and we need to find ways to improve in all these areas. I want to refer back to this image Kathy showed in her presentation. This is where we would like to see cows positioned so that they have access to the support they need at the right time. Here we have the PAWS and cows in the middle. They are in the ALS and MND journey together. We realize that they have their unique set of needs and rights, but they do cross over, and we have to remember that the PAWS and cows are a team. They work together, and the quality of life for both of them is highly dependent on how the elements around them work. I really want to highlight with this image that cows also need support for their physical and mental health, and the multidisciplinary team is key to support both of them in the different ways they will need. Always taking into account that no caregiver situation is the same. There is no one size that fits all, and what might work for one caregiver will not always work for another. So we need to build a variety of support professionals, services, and networks. And I want to mention, and there also the need for a local ALS MND association, which is key. And that we need to keep listening what caregivers are telling us to see how we can provide them with the support they need. Thank you very much.
Thank you so much, Jess. As the chair of the PAWS and Cows Advisory Council, I just want to add that the work that they did putting this together was, just incredible. And, just to share that we as the Alliance, we see this as a universal issue, and we want to advocate for increased caregiver rights, and whether it is for this emotional support, whether it's financial support, or a host of other issues that caregivers they face every single day. So thank you so much for that.
No, my pleasure. And thank you for everyone who sort of shared and took part. And we had I think what made it different for us to be able to get so much data was that we were able to translate the survey into 10 different languages, thanks to the support of the member associations. And that allowed us to capture data from other parts of the world, because the challenge is sometimes it becomes very English speaking focused. And that allowed us to sort of really, get a sense of what is happening at a global level.
You're muted, Rachel.
Richard, just on mute.
Yay, thank you. I'll start that bit again. But Jess, thank you so much for that. And I think you've given us a kind of a great insight on a macro point, kind of globally, and kind of exploring things worldwide. I wonder now if it's time to bring things down slightly more of a personal, on an individual basis. And one of the things that we see in our clinics is that caregivers are a hugely valuable they play a hugely valuable part in the care of the people that we look after, but they don't necessarily always identify themselves as caregivers particularly in the early stages of the disease, where they may well be partners, wives, husbands. And I wonder if Bugyeong, you can talk to us a little bit more about that in terms of caregiver identity.
Thank you, Rachel. So as I see patients' disease progression, I also see the caregivers' role transition and the family dynamic in between. So in early phases, both patients and caregivers want to be independent and try to cope with the disease in their own way. So some patients want to visit their clinic by themselves and make their own decision and does not want to be a burden or homework for their family member. And caregiver as well wants to respect the patient's identity and do not want to interrupt. However, as the patient requires more assistance, then caregivers slowly becomes their arms and legs and becomes their voices as well, and sometimes make some decisions for them. And the transition sometimes seems really tough for both of them. So some does not want to accept the fact that they have to rely on their family member, and the family caregiver also feels very overwhelmed and sometimes scared and feel heavily responsible of their care. So I feel sorry when the caregiver feels pity for the patient or pity for themselves and hide their tears. And sometimes they feel vasculations and weakness as well as they see the patient progress. And anxiety and depression is also widely recognized. So here I hope to see we can find a way to help the transition and actively cope with the caregiver role slowly and less painfully.
Thank you, Bugyeong. And I think we'll talk more about that definitely as the discussion goes on. But I wonder if Melinda, you could, we'll have some sort of insight into the sharing of caregiving identity and the work you've done with children and youth. And I wonder if you could share some of those points with us now.
Yeah, absolutely. And it's an interesting thing because, you know, globally, we still don't recognize immediately that a child or a youth would necessarily even be a caregiver. So whether it's the professionals kind of saying, oh, is this child actually participating in care? That's a critical piece. But also the child or youth, in really all of my clinical work and my research, they don't identify themselves as caregivers. They don't put themselves out there as being a caregiver. They might use different words like a helper or a supporter, but they don't identify as labeling themselves a caregiver. That's really more of a professional term when it comes to children and youth. So, you know, that's a really critical practice piece, understanding that what they want most of all is simply to be included in the process and be acknowledged as a part of it, but that they don't necessarily use that word caregiver. And I think that's a really important piece when you're working with the family unit as a whole.
Yeah, that's a really, you know, interesting point.
Mm-hmm.
That, you know, we know obviously we just automatically use certain words, and they might be like, no, I'm just
yeah, it just doesn't necessarily ring true with them, but using different words, helping, supporting, doing stuff to be with them, you know, that's what resonates with them a little bit more than the kind of clinical word of caregiver.
So then for both of you, are there things that we can do to kind of help normalize this experience?
I would say that first and foremost, don't be afraid to ask questions and be comfortable yourself. And it's about modeling inclusive language and inclusive behaviors that acknowledge that family units act as caregivers and provide care and provide support, and that they often feel like they're the only ones doing it, or they feel very kind of othered or isolated. But as professionals, if we aren't afraid to ask the tough questions, if we aren't afraid to acknowledge and help people understand that all over the world, there are people doing some very similar types of things, it helps to break down that kind of social isolation that caregivers caregivers across all ages feel. But it's often incumbent on us as healthcare professionals to just not be afraid ourselves and put it out there and ask the tough questions in a very normal, inclusive way.
Bugyeong, do you agree with that? I see you nodding.
Yeah, I think it's really tough to bring the topic to a young caregiver, and sometimes if they are in their adolescent, that they understand the genetics, understand the disease, then I think it gets tougher to balance the information and give the prognosis or break the bad news to them. And I think also for them, it's physically and psychologically demanding. So
Marcella, I just noticed in the chat, wrote, she was 14 when her father was diagnosed, and she never thought of herself as a caregiver. She was always a daughter. It's not till now, looking back, that she realizes that she was both.
Yeah, absolutely. Thank you, Marcella. It's a really powerful addition.
Yeah.
We have patients with it in our clinic, and when they come to clinic, they have their young children who may well get a drink out for their parent or pass them something. And I guess, they're tiny people, and yet they're doing these things, and technically they are caring, and it has a massive impact, and the parent's very proud. But it's Melinda, what do you do in those situations?
Honor it and acknowledge it. Respect the fact that they are stepping up and doing something to help. So many of these children exist in the fringes because, and it's not solely, but as a society and definitely as healthcare professionals, we don't know. We're like, oh, I don't know how do I respond? What do I say? Is this weird? Is this good? Is this bad? Children very often feel a huge sense of pride and accomplishment, whether it's a massive, complicated care task, or like you said, simply reaching for a drink to help their loved one have a sip out of a straw. They want that acknowledgement. And so for us to simply act like it's a normal act of care and kindness from a family member, and it's not weird that child happens to be 8 in doing it. But yeah, a lot of it is really education on the professional side, on being comfortable with it and being okay to just acknowledge the love and the care that went into that.
No, that's really interesting. I think about the MND and the ALS journey along the timeline from pre-diagnosis through to diagnosis through to when somebody dies. We have to think about a lot of interventions, and some of them are, the best for the caregiver at specific points in time. And these interventions can be, so incredibly vast amount of different things, like emotional support, financial support, physical support, information, education, training, and a whole host of other things. And I think at times in our clinic, we don't do this. We certainly don't cover all of these things at all. And sometimes we do little elements of something, but not by any stretch of the imagination, all of these things. And I'm wondering, Jess, if you can talk about what you feel that we should be doing in an ideal situation to help the caregivers.
Looking back, because it's very easy just to look in hindsight now, rather than when you're actually living it itself, I feel that the caregiver is also going through an ALS MND journey, and that starts from even before diagnosis, when they see that something isn't right with the loved one that is being affected. So when the news comes of the diagnosis, and personally I wasn't there, it was my dad who was there when they got the diagnosis, and when I hear him talk about his feelings about that, it's heart-wrenching. Sort of like his world collapsed at the same time as my mom's collapsed. But all the attention, and surely, the person that has been diagnosed has some really urgent and immediate sets of needs, and everyone, that's where the 100% of the attention, and the caregiver and the person, that loved one that's right next to them, is going through a whole other roller coaster of emotions. And his emotions are very different to what my emotions were. You know, we're talking his life partner who he was looking to grow old with, and pension, and they had all this long-term sort of end of life plans for them together. And I had a whole other set of plans for myself. So there's an emotional component from the very beginning that I think is lacking with regards to sort of helping those that are going to gradually become that primary caregiver to understand what they need to do for caring for themselves and for their emotions, because it's so easy to just forget about your own mental and physical health. And that multidisciplinary team that we put together for the person living with ALS, I think there needs to be a multidisciplinary team available for the caregiver, because nutrition, being able to find time to eat for themselves, find time to go and eat, find time to sort of go for a walk, find time to go and sort of talk with someone, that is a multidisciplinary team. And then, of course, all the other emotional and support networks, which what works for someone, so what would have worked for me will not have worked for my dad. We're talking about an age difference. We're talking about relationship with the person, which is completely different. And I include children and youth in there too. What they will need is going to be completely different. And having sort of, they might, having the option and knowing that, okay, I'm stressing out, I need help. Okay, what can I have access to? And you go through that, but it doesn't stop then. You've got the palliative care piece, when sort of you're reaching sort of a more advanced stage and you are suffering as a caregiver. And my suffering, as hard as it was, I could see my dad's suffering was a very different type of suffering. And then when the journey ends for the ALS MND patient, it doesn't end for the caregiver. So, and that I think is sort of a conversation we need to start talking, as tough as hard as it is, because we don't want to talk, when you are at that time, you just don't want to think about it. You just really do not want to think about the moment when that loved one is no longer with you, but you are in this bubble for how many years taking care of them, and the world is moving at a very slow motion. You just don't know what's going on around you. Well, that was in our case. And as far as you sort of know where it's going, because it's progressive, when the day comes, you're still in shock. You still don't think that day, that night before, you don't think that the day tomorrow is going to be the day where, the last day. And you're thrown into this grief and this shock, and you're suddenly no longer a caregiver. This time that you sort of been spending 200% on your attention on someone else. And I do think there is a major piece of work that we need to be doing there, so that caregivers know what their options are, sort of, so that grief is manageable. Yeah, so I've extended my, I'm very emotional about this topic, as you can tell, but I do think that there needs to be a whole infrastructure of support on all areas that helps the caregiver through their journey from diagnosis till after diagnosis.
I think your passion is the one thing that gets things done and makes some changes. So don't stop that, because that's the thing that makes a major difference. And I'm thinking just that you mentioned kind of towards the end of life and somebody may die. For the caregiver, I can only imagine there's a mixture of emotions that are attached with that, because in one respect, on one hand, you're relieved and things have come to an end and people are peaceful, and yet the loss and the grief, and as you say, the emptiness that you have. But there's a kind of a myriad of kind of emotions, I should imagine, after that happens.
I don't think there's enough words to describe the sort of amount of emotions that sort of come to you. And I'll speak for myself, but I also sort of saw my dad sort of, his life partner. I know when she got diagnosed, they had just sort of celebrated their 43rd year anniversary, and they had so many plans together. So his loss, there was a grief of me for my side to my mom, but I also was grieving for my dad, or for his loss. we made a team, our relationship became so much closer because of the experience. And, even from that sort of, I decided to stay in Colombia and not move back to, not relocate back overseas. And, it has been us, as a team that we sort of have been working through our grief, because even sort of 3 years down the line, we still grieve. We still have our moments, but yeah, I just got myself a little bit emotional there.
I'm gonna say, I swear, Melinda, it wasn't set up, but Jess, that just really ties right into the presentation we had just before this, where they did the interview with 6 surviving spouses, and the timeline. It really does link very well together.
No, and I do think that there is, and every person is different. And I think that is the challenging bit, that we won't be able to find a solution that fits all. We won't be able to create a protocol, to put it that way, and be very sort of specific about it. There isn't, we just need to start building sort of the options available for caregivers so that they know where and when and sort of how they can reach them. Also, the language barriers, sort of, I think there's a lot of stuff out there that we have seen throughout the last few days over the APF. But, what can we do to expand that so that, everywhere in the world we can sort of, have access to them, because not everyone speaks English. And, I was lucky, I was brought up bilingually. I can defend myself in that way, but still a lot of the information out there for caregivers is in English, and it's scary. It is so scary when you, especially at the very beginning, you don't understand half of the things that you're reading, even when you feel fluent in a language. And I just, if I was to sort of look forward and sort of think what would be my, best case scenario, is that caregivers have an international support network that allows all ages, all type of caregivers, all types of profiles, and it will take time to put it together, but that we can, that they know that they're not alone, because it's that feeling of loneliness and just that no one understands, and feeling judged and feeling that they're not doing right for their patient, and then self-doubt. That's probably the guilt that comes around the self-doubt, when you sort of feel like you're losing part of your life because of ALS. And there's so many feelings. It's and the caregiver most of the time is trying to navigate them on their own.
Yeah, absolutely. And I know at our center we do have a mental health specialist, but when we look at it, we look at her as one piece to the interdisciplinary team. But when you shared Acela's vision, the person was split in half, and half was physical and half was mental.
So that image you're referring to that was actually something we put together with Kathy on our discussions. So that's the Alliance's vision. Okay. Because this is what we sort of see at, at a global level. We see sort of the sort of what needs to go around sort of the person living with ALS. And sort of what we want to sort of start seeing is that the PALs and CALs are a team. They work together. For them to have both quality of life, they need to work together. If one isn't well, the other one isn't well. If CALs isn't doing well, the PALs is going to be affected. So we need to sort of start seeing them as a team. And when we're sort of assessing and working sort of, okay, why is someone, showing some type of depression, I'm going to say, let's find out what is around and how is that affecting the caregiver, and vice versa. And we need to sort of start incorporating more the caregiver as a key factor on what's going on. So that was that image for us, is to really sort of start and see them as PALs and CALs, not just PALs on their own and not CALs on their own. We want to sort of see that more of a union of how we see the support needs to be.
All right. So let's just go around the globe then. Bugyeong, how can you talk about how professionals are injected into the journey for people in Korea?
So for me as a nurse coordinator, I think my job is to connect patients and family with the right professional at the right moment, And as I hear Jessica's talk, I really appreciate that you share your personal story. And I think it's important that in Korea and other country in the world, we share the same emotion, we have the same difficulty, and we share it together. I think it's really important to have their personal story. And I want to share the story with the patient and family and have them enough information when they need it. So sometimes we have too much information that overwhelms the patient and caregiver. They think they have to study the materials, but at the same time, patients need more information. They need more personal stories and share the same story with their friends and family, or the patients and caregivers who know how exactly they feel. So in my clinic, we have a group of patients and family. They met in our clinic when they wait for their doctor's appointment, and they become friends and they share their stories together. And now they sync their clinic visits schedule, and they meet in the hospital and they share the experience together. And I think it's really positive that coming to the clinic is not a fun experience for all of them, but meeting their friends and sharing experience along the journey is really important. And it's sad that COVID-19 situation, we restrict the family gatherings, but I think in a virtual way, or any other stories in a virtual forum or Alliance webpage connection, Twitter as well, I think if we can share their personal stories in more detail, and if we professional can navigate the story to the right person at the right moment, I think it's really important for their mental health.
Mm-hmm. Yeah, absolutely. I could picture immediately when you said, somebody meets like-minded people at the clinic, and they're like, okay, so you're coming back in 3 months. What day are you coming? Yes, I can.
Right, exactly.
Picture that. How about Melinda? Can you speak to directly to some of these questions Jess brought up, the end of life and then the grief and.
Well, yeah, I mean, I think really the absolute key piece, and we talked about it really briefly earlier, is normalizing the situation and recognizing that people aren't alone in it. And I think regardless of where you are, if you're in the United States, if you're in Colombia, if you're in Korea, it can be such an isolating experience, caregiving, because of the intensity of it, and particularly what ALS brings as far as the intensity of care needs. So I think more than anything, it's engaging with professionals who are comfortable with those conversations to help normalize that they're going through these things, and figuring out ways that, all caregivers, they need acknowledgement, they need support, and particularly as you move towards the end of life. And that's something that is a very uncomfortable conversation for family members, but also for healthcare professionals. We're very much trained in the care and support, and it's awkward to have to talk about what's going to happen at the end of life. And families really struggle, particularly with this idea of anticipatory grief. And it's a very clinically term, but really all it means is that people see the end is coming, and people recognize that those things that they're losing, their loved one, Jessica, that normal experience of your mom and your father's understanding that his life partner is going to be gone at some point. And, those kinds of aspects. And for kids, dad's not going to be able to play football with me anymore. And suddenly, his voice is gone. So it's really trying to be, as professionals, cognizant of this anticipatory grief, this progression towards the end, and how can we build supports along the way so that when that end comes, as Jessica so eloquently stated, it just happens, poof. But yet there's been a lot of things that have been losses, gradual losses, sometimes tremendously huge losses along the way. And that idea, that conversation around end of life has got to be engaged much earlier, much earlier, to be able to not end up with, kind of complicated grief, which is really the thing that sticks with people for so many years, because they didn't have that ability to process, to discuss, to get the support earlier. And then the loss happens, and they've lost their loved one. They've lost their identity as a caregiver, however they identified themselves. They've lost so much. And so for professionals to be able to get ahead of that and sit with how you feel about end of life. And this is, sorry, I won't go off on a huge tangent, but often professionals aren't the ones that have really thought, how do I feel about end of life? How do I feel about death of dying? I'm going to sit here and talk to this family member and this loved one, and yet I'm squeamish about it. Right. And so everything that we can do as professionals to sit with our own understandings and our own biases and our own comfort levels around end of life, and then be able to provide that support, that really well thought out support to our family members and our caregivers and our patients, that's really critical to helping them be able to transition kind of into that next stage, if you will. So sorry, end of life is something I could talk about for 80 hours. No.
Melinda, I so agree with you. And I think from my perspective, I think when firstly, I'm a rehab nurse from background, but my neuro element, I think of it in terms of neuro palliative care. So together, so it goes hand in hand. And I think there are many neurological clinics that are very, blinkered and things, but I think from an M&D perspective in our team, we're very much more neuro-palliative. And so we don't necessarily have a palliative care consultant in with us, but I think we do that kind of work throughout the journey of the patient. I'd like to think we do, but we never. When I sit here listening to everybody talking, most of the time I'm thinking, okay, I could do better. I could do so much better. I just need more time.
We could all do better.
There's such a complexity in everything as well, too, because you're talking about, Melinda's talking about making sure we're getting it, we have to bring it up early in the conversation, but then, it's also been pointed out by Jess and Bugyeong, just like the person has to be ready to hear it. Like, it's so complex.
Absolutely.
Sometimes people are just like, okay.
It is about building those relationships,
right?
And that trust, and it goes very, very, very much back to the very first time we meet in the diagnostic clinic, and the time we can spend there starts the whole relationship. I think really is the diagnosis, or that first appointment, is absolutely pivotal, because if people at that point can begin to trust you or think that there's a kind of, they can take a breath and know that you're there, then the journey can begin. And I think if people have had a very poor diagnosis for whatever reason and wherever, that can set a really bumpy journey for the whole, the whole of the thing. And you spend a lot of time unpicking to get to the point where the acceptance comes. And I think so it is a whole long line, starting at the very beginning, I think. I don't know what you think, Melinda.
Oh gosh, I couldn't agree more. I think both you and Sara, right on. It's so fraught. Like, that's the word that keeps coming to my mind. Like, it's just fraught. It is not a totally set in stone A to B to C process. And I think it's something that we all, as professionals, as researchers, as supporters, have to be constantly reevaluating. How are we engaging that client at the very first time we meet with them? How are we consistently engaging them? And I know COVID has really put a lot of barriers, because we aren't that hands-on that we always used to be, but I think absolutely there's no definitive playbook, but if it's about us as professionals making sure that we are constantly reevaluating, are we integrating these conversations? Are we having them early enough? Are we engaging our clients and their family members at the earliest possible way to be as supportive as possible across, right, adults and children and the patient? How are we constantly reevaluating the work we do to provide the best possible support for them, so that they don't get to the end and feel completely just decimated? So yeah, I don't know. It's such a wonderful conversation. There's no like definitive answer, but
And
yeah,
there's even more complexities. There's a person who comes in without a caregiver initially.
yes.
You know, they come by themselves. And then somebody has also just put it in the chat. What about the couples who aren't getting along?
Oh, yes. Yes, I've seen many of those in my clinical practice. Well, because often, even if someone is getting along really, really well, there's a thing that happens when the spouse transitions to being a caregiver, right? And I think someone, I'm not sure if it's here or in the symposium, they're going to talk about sex and ALS and intimacy. And those are things, it's here. Okay, thank you. Those are such critical pieces because again, it goes back to that idea of I'm a caregiver. Is this my job? Is this still my spouse? Can I still have sex with them with this, disorder or disease that they have? And if you don't have that kind of good connection first, it's a real struggle to put through that long, very emotionally charged, difficult caregiving process. So I've seen it with couples who don't get along well, and even couples who get along really well. It just dramatically changes.
But I think for those, this may sound, I'm going to say it out aloud, maybe not so, yeah. But MND changes very quickly, and it's a relatively short period of time. For other kind of neurological problems or degenerative things that last 20 years and longer, couples sort it out and they may well separate quite early because they think, do you know what, I can't have a long lifetime like this. But MND has such a short changing period. The caregivers, the partners, the whatever, there is a massive, they can't really leave at that point. It's not really the easiest time, and they may well think, okay, I've got a year or I've got this, but that's really challenging for a relationship, and it puts an extra burden on the family, the children, and everything, just because things are changing so rapidly. I don't know. Bugyeong, is that something that experience with?
All right. So now we've framed the problem. But how about I'm sure that people are now going to be looking for what are some concrete things that we can be doing? Yeah. How can we empower the caregivers, no matter where they are in the world, we know, and we can tell looking at the Q&A, there's plenty of people who are sitting here right now who could be on this panel. This is not just limited to us. Yeah. There's so many other people. Everyone has their own experiences. So what resources, what can we offer to people? I know,
Lisa's just saying in the chat, I wish this conversation could go on and on and on. You probably won't. You'd want us to stop very soon.
In November, it was Caregiver Awareness Month in the United States, right? And then what was it like? There was a day, November 13th in Canada, that was Caregiver Day. So people are talking about it. So what can we do?
Yeah, I think the main thing is to always bear in mind that the situation of a caregiver is not the same with everyone. The story will change from one person to the other. So one circumstance, let's say if I'm just sort of seeing here a message of, should we say, give them the option, like it needs to be looked at a case-by-case scenario. You cannot sort of say there are no red flags and a direct route about it. It's just not like, you take a, you have a headache, you take an aspirin. No, it's a whole context that will always need to be taken, into account. What's the support network that the family has? That will have a massive impact with regards to how they can manage the ALS and MND journey. One thing, if it's just the age of the family, age is an issue. Where are the children, the age of the children, the interactions between them, everything, all of that has an effect. And the amount of, I think there are a lot of resources out there. I'm not sure how we're doing with time. I do want to sort of plug that in the sponsor section, the Alliance has a booth with a lot of resources. We've put Melinda's guides in there. You can download them in there. We've sort of included all the, the majority of the links and, resources. Towards the end, I will sort of give you a little bit of a taster around a video that we've got from Kendall Maxwell, sort of with regards to sort of meditation rules and everything. So I probably would sort of say maybe let's show it now, just so that I can give you a little bit of a taster, and then we can carry on the conversation, if that's okay.
Well, we're actually probably getting really, how long is it?
It's like a minute and a half long. It's a minute and a half long, the video. It's just a taster, so everyone goes later on and watches it at this.
Yep, we've got 7 more minutes.
I wanted to talk a little bit about how to reduce caregiver burden. Frequently, when I talk to my patients and their families, we're discussing how the patient's doing, but really, this is a family system disease. There are many times where people are caring for their loved ones and are not taking care of themselves. This is easier said than done. A lot of caregivers frequently say to me, I don't have the time. How can I even do that when there's so many other things going on in the day? But we can create small moments, and understanding that perspective and using that to our advantage is incredibly important to reduce caregiver burden, because the research is there that if a caregiver is having depression or anxiety or is having a low quality of life overall, it actually not only impacts their mood, but the research is there that it also impacts the patient's mood and their quality of life and care. So it's important to take care of yourself because it also affects who you're caring for.
So if you want to learn more about it, the full video is in the booth section and in the sponsor section under the Alliance resources. And we've also got all of Melinda's guides that she has shared with us with regards to the, how to communicate with children. There's a great range, Melinda. I enjoyed looking through them yesterday. And
Yeah, actually, Melinda's books, Bugyeong, you and Melinda are going to work together now, aren't you, on translating those books
into Korean?
Yeah. Well, I was really surprised and really touched by Melinda's book that it leads a new way to see the world, see the ALS community as a whole. That her book, it says like it's okay that your friend is late for school because he has to help her mom help her mom having breakfast. It's okay, you can support your friend. And I think this is the way that we have to see ALS, and we have to take care of the journey together as a society. Now we don't have a cure, unfortunately, but until we have a cure, we have to find a way to live with ALS, and that's what we all hope in the Alliance and each association does as well. So in Korean Association, we are now focused on amend the policy to help caregiver, especially financial help. That we talked briefly this about in the backstage that in Korea, family caregiver can get financial support remuneration from the government, but it's really small. I think it's important that the government acknowledges that caregiving, family caregiver is a role, is a job that should be paid and recognized. I think it's important that it's the first step, but it's not enough. So we now try to amend the policy to support at least a patient with tracheostomy and 24/7 respiratory support. The caregiver, family caregiver should be recognized and put into the boundary of the policy and wants to expand. And I hope there are systems like this in other country. There may be better or less. And if the globe can work together to the same goal, same future, I think we can follow along with them, and maybe the family can get benefit in their local level as well.
Mhm. Absolutely. And I think that's something the Alliance can help with, is to show what is happening in different countries. What is the level of care? How are the people being remunerated? What is happening? And then hopefully that can help raise it up throughout the globe, when you can say, look, other people, this is working in other countries. How can we make it work in ours? Absolutely.
And we will definitely work with Melinda and share your story, your book with Korean patients and family. I'm so excited.
I know, me too. I'm super excited. I'm glad that you speak Korean and I don't, but we'll absolutely collaborate on that.
And maybe we should just put it out there then, if there's people on this meeting who are interested in having it in another language, contact Melinda.
Absolutely. Please do. I'd love it. I'd absolutely love it.
I think we haven't got that long, Sarah, now.
I think we have a minute.
We have a minute.
We can talk forever about this.
Yeah, we really do. I think we have a minute just to really thank you all for coming and your expertise. And as some of the chat says, they could listen to you talking forever. But I think it's an Icelandic. Can you do that?
I just saw that. Sure.
You have to go to Iceland.
I'm good with that. Yeah.
But I think Sarah and I would just really like to thank you all for coming.
Yes.
And just the time has absolutely flown by, and we haven't really talked about half the things we were going to discuss, but we really want to thank you all for your kind of your insight and helping us understand a different side of the whole picture.
Yes. Yeah,
Thank you for
not only understanding it, but just knowing that there are things that we can do, and knowing that, you know, other people are going through something similar. And I always learn from this panel, and just pick up on something different I can do, and a different way I can approach things. I know
it's an honor to be here.
Yes. No, thank you for having and for listening.
This is definitely a priority for the International Alliance to move this forward, working with the fundamental rights, working with caregivers, now having Jess as on staff. So this is just going to keep moving forward. I just want you to all know that. And again, thank you. And if there's anything else, we are at the end, but if you want, you have 2 seconds.
Thank you very much. Thank you,
Yes,
everyone.
thank you.
Everything,
Thank
for
you
all
so
your
much.
contributions and sharing. Thank you.